Welcome to this module on health system resilience to mitigate, adapt to, and recover from disruptions in HIV service access and utilization. The information contained in this module is designed for those providing HIV care, physicians, nurses, pharmacists and community health care workers, and for communities of people living with and affected by HIV. It aims to build capacity to provide evidence-based, appropriate, quality, accessible HIV services. On completion of this module, you will be able to describe health system resilience and why it's important. List the 5 elements of health resilience framework. Understand how a resilient health system is a precursor of a resilient health workforce. Explain how PEPFAR managed to continue services during the COVID-19 pandemic. Describe lessons learned and how to use them to support future resiliency. Let's start by defining resilience. Throughout the COVID-19 pandemic, PEPFAR has remained committed to continuing essential HIV prevention and treatment services, while maintaining a safe healthcare environment for clients and staff. In order to meet the commitment to uninterrupted care and treatment for people with HIV and the prevention of deaths due to HIV-associated comorbidities, PEPFAR has been committed to adapting HIV services, so that PEPFAR beneficiaries have the best possible outcomes within the context of stretched healthcare systems. Despite the disruptions caused by the COVID-19 pandemic, a number of countries have achieved epidemic control in 20 Colombian pesos, and others will achieve epidemic control in 21 Colombian pesos. With continued improvement, most PEPFAR countries are on a path to achieving program coverage goals. With that in mind, PEPFAR programs should highlight 4 key themes in planning and implementation for 21 Colombian pesos. Client-centered services, community engagement, resilient and adaptive approaches, support for sustainable capacity. USAID defines resilience as the ability of people, households, communities, countries, and systems to mitigate, adapt to, and recover from shocks and stresses in a manner that reduces chronic vulnerability and facilitates inclusive growth. Health system resilience is defined as the capacity of health actors, institutions, and populations to prepare for and effectively respond to crises, maintain core functions when a crisis hits, and, informed by lessons learned during the crisis, reorganize if conditions require it. Resilience work is about strengthening abilities or capacities so that people and systems may absorb, adapt, and recover from shocks and stresses. Absorptive capacity describes the ability to minimize exposure and sensitivity to shocks and stresses through preventative measures and appropriate coping strategies to avoid permanent, negative effects. Adaptive capacity is the ability to make informed choices and changes in strategy in response to longer-term social, economic, and environmental changes. Transformative capacity describes the governance mechanisms, policies and regulations, cultural and gender norms, community networks, and formal and informal social protection mechanisms that constitute an enabling environment for systemic resilience building. Resilience occurs at multiple levels. People's needs and household dynamics affect their response to various challenges and emergencies. These responses occur within the cultural context of a household or community based on amount and level of social capital and skills. The state of the health system and institutions in which these responses occur impacts the number and quality of options available to individuals, households, and communities. Resilience isn't just about bouncing back after shocks. It also includes active and deliberate management of potential and actual risks. Building resilience and coping strategies is not just important during short-term shocks and time-bound events such as disease outbreaks, political instability, slow-onset drought, rapid-onset flooding, or market shocks. Resilience is also critical during longer-term dynamics such as protracted displacement, weak government authority, population pressure, social exclusion, and climate variability. Let's start by defining resilience. Resilient health systems are characterized by 5 elements. First, resilient health systems are aware. resilient health systems have an up-to-date map of human, physical, and information assets that highlight areas of strength and vulnerability that allow for detection of health threats before they strike. Second, resilient health systems are diverse. Health systems that have the capacity to address a broad range of health challenges rather than a targeted few are more stable and capable of detecting disturbances when they arise. Third, resilient health systems are self-regulating, with the ability to contain and isolate health threats while delivering core health services and avoiding propagating instability throughout the system. Self-regulation has three elements. 1. The ability to quickly identify and isolate a threat and target resources to it. 2. Minimizing disruption to provision of essential health services during crisis. And 3. The availability, in particular locations, of excess or redundant capacity that can quickly be brought online. Fourth, resilient health systems are integrated. They bring together diverse actors, ideas, and groups to formulate solutions and initiate action. Sharing of information, clear communication, and coordination of multiple actors are hallmarks of integration and are best achieved by having a designated focal point in the health system. Fifth, resilient health systems are adaptive. Adaptability is the ability to transform in ways that improve function in the face of highly adverse conditions. Any adaptations should enhance performance in the short term and, ideally, contribute to building long-term resilience. International panels reviewing the Ebola response have called for measurement of health system resilience capacity ahead of crises. Building on the conceptual framework described in the previous slide, the Resilience Index proposes a set of preliminary measures of national health system resilience designed to help countries assess whether their health systems can withstand future shocks. First, the element of awareness. The first aim is to know the health system capacity. Measures include distribution of health system assets and weaknesses and health service utilization trends. A second aim is knowing the risks in the population. Measures include presence of an active epidemiologic surveillance system and a functioning civil registration and vital statistics system. A third aim is communication. Measures include a list of decision makers in key sectors and the breadth of functioning communication channels. Second, the element of diversity. The first aim is effectively responding to a range of health needs. Measures include the scope of health services available in primary care and quality of care for sentinel conditions in a basic package. A second aim is adequate financing of health systems and preventing financial harm. The measure is financing of healthcare with adequacy of government health expenditure and financial protection. Third, the element of self-regulation. The first aim is the isolation of threats and maintenance of core functions. Measures include memorandums of understanding with non-state providers and a database of service delivery alternatives for affected and unaffected populations. A second aim is leveraging outside capacity. The measure is collaboration agreements with regional and global actors. Fourth, the element of integration. The first aim is coordination with non-health actors in areas such as education, transportation, police, media, and private enterprise. Measures include existence of a national emergency coordination system and leaders, frequency of joint planning sessions and drills, and a process for development of a One Health strategy. A second aim is engagement of citizens and communities to build trust. Measures include an index of Ministry of Health and government responsiveness to community need, population trust in the health system, platforms for dialogue with community leaders, and in-country social scientists with experience working with health departments. A third aim is linkage of healthcare provision to public health. The measure is availability of district health staff with public health training. The final aim is coordination of primary and referral care. The measure is agreement on roles and referral protocols for facilities. Finally, the element of adaptability. The first aim is shifting resources to meet need. The measure is formal provisions to reallocate funds in emergency. A second aim is promotion of rapid local decision making. Measures include management capacity of district or local health teams and agreements on delegation of authority and funding in crises. A third aim is evaluation to improve. The measure is mechanisms for, and capacity to, track progress and evaluate health system performance in crisis and in times of calm. The final aim is coordination of primary and referral care. The measure is agreement on roles and referral protocols for facilities. PEPFAR programs should invest in building health and social service worker resilience to reduce the risk of burnout and preempt longer-term mental health effects. A resilient health workforce needs hardware such as telephones, gasoline, water, electricity, and road sand. Software such as government support for competency-based training, empowerment of healthcare workers, and an understanding of where informal and private sector providers are providing services. Steps to increase health workforce resilience include the following: ensure a safe working environment to support healthcare worker physical and mental health. Routine wellness checks to determine emotional and physical well-being and maintain responsive services. Teach skills to increase resilience. Ensure that staff have access to mental health services and encourage staff to utilize the support. The first step in boosting health workforce resilience is to build and foster a culture that values employee well-being. Actions to support this may include the following: schedule 15 minutes a day for a mental or physical break. Research wellness tips to send out with team meeting agendas. Summarize and share tips from healthcare sector wellness literature with team members. In meetings 5 to 10 minutes early so participants have time to respond to emails and prepare for next meeting. Create an anonymous engagement survey to send to staff on job satisfaction and wellness needs. Include a wellness activity in team retreats. Dedicate physical spaces for clinical staff to decompress and recharge, such as staff lounges, coffee bars, gyms, and libraries. Reward staff at all levels so people feel appreciated and that they are part of a larger team. Here are some strategies to promote well-being and teach resilience skills. Optimize a challenging working and learning environment. Promote connectedness. Build skills and mindsets. Provide virtual resources for well-being and support. Identify and assist trainees in distress. Deliver coordinated crisis planning and management. Just as you might pack a go kit when planning to enter or exit a disaster zone, it is useful to pack a psychological go kit in preparation for managing stress. Your coping strategies. Consider strategies that you have used to cope effectively in the past. What can you do deliberately to manage stress? What new thing are you willing to try? Your soothing strategies. Consider strategies you use to manage your emotions and to calm yourself in the moment. How do you recover from an anger storm, fear, or anxiety? How do you calm yourself before sleep? Awareness of your stress scale. If 1 is no stress at all and 10 is the worst stress you have ever felt, monitor yourself throughout the day. Where are you on the stress scale? Catch yourself in the mid-range and use calming and coping strategies deliberately. Your psychological emergency contact list. Create a list of people who you can call on for emotional support. Ideally, this should not be just the one person you use for your usual emergency contact. Expand your list to include colleagues, friends, and family members. To combat clinician burnout, organizations and organizational leadership must prioritize clinician well-being and implement solutions that create an environment in which all clinicians can thrive. The viability of our health system depends on it. The initial experience with the COVID-19 pandemic led to lockdowns, fears about risks from clinic visits, disruptions of supply chain, and social distancing requirements, all of which threatened to disrupt HIV services. PEPFAR teams demonstrated the value and the critical importance of being equipped with contingency plans and capacity to rapidly respond and adapt to pandemic illness and other events, for example, natural disasters, civil unrest, that can disrupt service delivery systems and patient lives. PEPFAR teams and programs exercised resilience in sustaining HIV services despite disruption due to COVID-19, and 21 Colombian pesos plans should draw on lessons learned from COVID-19 to ensure systems of service delivery and the people who implement them are safe, secure, and resilient. The initial experience of PEPFAR since the onset of the COVID-19 pandemic has been mixed. but key top-line aims, linking people with HIV with care and sustaining them on life-saving treatment, have been met, as overall program growth continued and continuity of treatment for people with HIV was largely successful. However, while PEPFAR and partner programs have shown remarkable resilience on treatment continuity in the context of COVID-19, the pandemic's impact on PEPFAR's and Global Fund's HIV, tuberculosis, TB, and malaria prevention programs has been devastating. The pain has been particularly acute for women and children as well as other vulnerable and marginalized populations, as these dual pandemics continue to reveal and exacerbate existing inequities in societies around the globe. COVID-19 has also shown the fragility of healthcare systems in some upper and middle-income countries, which due to their relative wealth have lost their Gavi eligibility, and that can impact their ability to access COVID-19 vaccines once they are available. Setbacks to global and domestic HIV responses brought by the COVID-19 pandemic will be felt for years to come. Disruptions to HIV testing, prevention, and treatment services threaten momentum toward global treatment targets. Without swift and strong efforts, disruptions in HIV treatment threaten the additional loss of 500,000 lives to preventable AIDS-related illnesses in sub-Saharan Africa, while interruptions to prevention of mother-to-child transmission services could double the number of children infected with HIV and in need of lifelong treatment in countries such as Uganda, Malawi, and Zimbabwe. In the U.S., clinics have reported declines in HIV screening and pre-exposure prophylaxis, PrEP, uptake and access, as well as declining rates of people with suppressed viruses, a crucial measure of protecting individual health and preventing HIV transmissions. Top priorities during the COVID-19 pandemic included reducing the time spent in healthcare facilities while maintaining a client-centered HIV service delivery approach, implementing modified infection prevention and control (IPC) measures to reduce the likelihood of COVID-19 transmission, continuing efforts to identify new cases of HIV while avoiding in-person gatherings, implementing virtual monitoring and evaluation strategies. The challenges of the COVID-19 outbreak highlighted several important lessons for HIV programs in the future. During an unprecedented public health emergency, HIV programs remain resilient through a combination of innovation and flexibility. Essential HIV services were maintained while keeping clients, healthcare workers, and communities safe. This was achieved through a combination of rapid scale-up of established interventions, as well as the use of novel strategies that had not been attempted previously. Ensuring resilient community-based HIV services during the COVID-19 pandemic required several innovative approaches, including scale-up of HIV treatment services in communities, including multi-month dispensing, decentralized drug distribution, and differentiated service delivery. Enhanced infection prevention and control measures. Leveraging of technology to deliver HIV services. Innovative approaches to reach key and disproportionately affected populations, and strengthening coordination and collaboration between key public health stakeholders. These approaches kept clients on treatment and reduced the risk of COVID-19 exposure for both clients and healthcare providers. The ability to act quickly was essential in ensuring the continuity of life-saving art while facilities were adapting to new COVID-19 safety protocols. Scale-up of HIV treatment services in communities involves ensuring multi-month HIV prescriptions are dispensed to stable clients in safe, confidential, and accessible community spaces. Reducing the need to visit healthcare facilities to reduce the risk of COVID-19 exposure for both clients and healthcare providers. Expanding community art refill services to multiple regions. Using innovative forms of transportation to provide HIV treatment and services to clients in hard-to-reach areas. As the threat of COVID-19 has impacted PEPFAR countries, PEPFAR country teams have accelerated interventions that permit clients to maintain continuous HIV treatment in the setting of lockdowns and social disruption while ensuring safety of clients and providers. Multi-month dispensing of ARVs, decentralized drug distribution, and differentiated service delivery are client-centered innovations that reduce congestion in healthcare facilities and allow clients to spend less time in the clinic, where they could potentially be exposed to COVID-19. These interventions have been accelerated during COVID-19 and this should continue. Separation of drug delivery from clinical treatment reduces the burden at clinical sites and allows more attention to the patients who need clinical evaluation. 6-month dispensing is preferred, but there may be circumstances where 3-month dispensing is necessary. At a minimum, most clients at ART treatment sites should be offered prescriptions for 6 months of ART, and a fast-track refill model at the site should be adopted. Differentiated service delivery is a client-centered approach to HIV care and treatment which tailors services to different groups of people living with HIV. Programs may consider utilizing decentralized service delivery models for ART distribution for stable patients through private sector channels. This may include decentralized drug distribution such as alternative pickup points in communities, retail, community, or pop-up pharmacies, home delivery, and/or automated systems such as lockers or pharmacy dispensing units. These models can help reduce patient travel times and waiting times while decongesting public facilities and reducing stigma. Country programs should ensure these approaches are in line with national policies for ART distribution. These interventions should continue post-pandemic. As community-based ART is scaled up, it is critical to ensure that safe infection prevention and control measures are followed. On-the-job training and information on best IPC practices should be provided to volunteers, staff, and healthcare workers. The COVID-19 pandemic has highlighted the need for robust IPC programs that protect clients and staff. All program systems investments should include provisions for IPC including administrative, environmental, and personal IPC protections. Well-conceived and carefully implemented IPC programs reduce illness, prevent death, improve continuity of services, and save money. Active support of IPC activities fosters a culture of safety in the healthcare setting. With the threat of COVID-19, all in-person HIV program activities such as meetings, trainings, orientations, and technical support, were halted and moved to virtual and digital platforms to ensure continuity of services. This approach proved to be particularly important for those services tailored to disproportionately affected populations such as adolescent girls and young women through the PEPFAR supported Determined, Resilient, Empowered, AIDS-Free, Mentored and Safe, DREAMS, initiative. DREAMS facilitators embrace the use of technology, including social media chat groups, online audio and web conferencing, and phone calls to schedule appointments, maintain outreach activities, and continue support groups. Different technology and digital platforms were used to provide HIV self-testing kits and pre-exposure prophylaxis to high-risk groups, as well as to perform virtual monitoring and evaluation of programs. To stop and slow the spread of COVID-19, large in-person events intended for HIV case identification were suspended and moved to innovative approaches such as self-testing and social network testing strategies. Social network testing involves engaging networks of sexual and injection drug use partners of clients living with HIV and ends the need for large in-person gatherings. Distributing HIV self-testing kits minimizes the risk of COVID-19 transmission for both outreach teams and clients, while maintaining efforts to identify and diagnose new clients living with HIV. Both HIV self-testing and social network testing are examples of innovative interventions that were already planned for scale-up but moved more quickly because of necessary safety demands of the COVID-19 pandemic. The COVID-19 crisis further strengthened coordination and collaboration between key public health stakeholders. Ensuring resilient HIV service delivery would not have been possible without commitment, dedication, and partnership between NGOs, regional and national governments, health management teams, community leaders and, most importantly, community members. The renewed strength of these partnerships will be a cornerstone of future public health response. Lessons learned during the COVID-19 pandemic will continue to be implemented as best practices in client-centered care moving forward. Community-based HART, HIV self-testing, and use of social network approaches to identify key and vulnerable populations were integrated into standard program packages. Interventions such as multi-month dispensing, decentralized drug distribution, and differentiated service delivery were accelerated to maintain continuous HIV treatment. Use of virtual platforms has proven invaluable and will increasingly be a key component of program planning, not only because of the benefits for health and safety, but also the potential for advances in efficiency and cost savings. IPC measures at healthcare facilities will also be critical, not only for COVID-19 control, but also for preventing the spread of tuberculosis and other infectious diseases that can be transmitted in a healthcare facility setting. Coordination and collaboration between key public health stakeholders was strengthened. Please take a moment to reflect on these questions related to what you have just seen in the presentation.